we looked at the pedicle anatomy as already discussed by Appaji. So you need to have these three important things in mind. So if you know the diameters, you know the angulation and the sagittal and coronal plane, you can never go wrong. So then so where is the pedicle is also important. Appaji has given you in detail in every level. It's like two funnels sitting over each other. That's the typical thing is D12 will be straight and up. You will go medially, and down also you will go laterally. So that's how things evolve. This is how the pedicle is, how you angulate at different levels. So the malpositioning of or the pedicle screw violation is very common. Studies have gone from 0 to 44%. This is the major complication. It can cause dural tear, root injuries, paraplegia, vascular injury. So when you put in these screws, there are the common structures on the right side you injure are the costal vessels, esophagus, the vena cava, thoracic duct, and bilaterally you can injure lungs on both sides, segmental vessels or sigmatic change. This is one classification which comes into play only when you have made a mistake. You normally don't classify them. So once you have a mistake, then you really look at it. And Gertzmann has really made it into 5 types, depending on how much is the malpositioning of the screw from 0 to more than 6 millimeter, and classified into A into E. So your breaches can be anterior, medial, lateral, superior. So wherever the screw goes, and if it hits an important structure, it causes a problem. So this is the Canadian study where they looked at the post-operative assessment of pedicle screw and management of breaches among the Canadian surgeons and developed a new scoring system. So they did it among a survey among the Canadian surgeons, asked them what they would do it if the screw is malpositioned in this way. So they used in plain X-ray and CT and came to a conclusion, as we all know, that more worrisome breaches are medial and least worrisome are anterior ones. So they looked if there's a breach and it is asymptomatic breach, most of the surgeons tended not to reoperate. So if there is a new onset of pain and less than 4 millimeter of medial and inferior breach in both thoracic and lumbar, 60% of the surgeons said they would reoperate. So if there was a breach and sensory loss and a breach on a CT, the 90% surgeons would operate for a medial breach and 70% surgeons would operate for an inferior breach. So based on this, they came up with a new scoring system which looks at the location of the breach, the amount of the breach, and the symptoms it has caused. So if the score is more than 6, it warrants a pedicle screw repositioning. So if you look at the mechanical strength of a lateral breach on a spinal pedicle screw fixation, looking at the maximum torque and sitting capacity, the repositioned screw or doesn't have a much major difference and we can get away with it. Then there are issues where there is a mechanism of medial wall breach. So medial wall breach can still happen after a correct cannulation of the pedicle. So what are the culprits? It's a change in the insertion angle or use of a pushing force to insert a screw when there is a resistance. So pedicle seems to be extremely tolerant to insertion angulation mistakes up to 10 degrees and tend to lead the screw into correct pathways. Screws without tapping notch seems to be safer than notchless screws. So Gertzmann and Robin said 4 millimeter safe zone is allowable. Melmont said it is up to 6 volts. So it is important. This is an entity which is basically depends on the clinical symptoms. So any breach, if it doesn't cause a symptom, is hardly noticed. The cortical violation doesn't mean neurological deficit always, but violation more than 6 millimeter often presents with a neurological deficit. How to avoid it? Appropriate entry point, screw diameter, and undervision techniques. The endoscopic probe to assess the intactness of the pedicle screw or a B-sound ultrasound can be used in some, but it's morely a theoretical entity. So verification of the track using a ball probe. So you can do it physically, you can use it with a ball probe. Radiologically, you can look at the pedicle with a K-wire or a pedicle marker. Physiologically, you can do an electrophysiological studies. So these are the three things which you will tell you whether your screw is right or wrong. So use a ball tip probe for pedicle screw placement, specially designed. So ball tip probe should be very, very flexible. And they did a study and looked at there's a 40%, 14% error with the ball tip, whereas it was 34% in the conventional group. So palpate and you check for all the four walls and the floor. So even if you feel at times on a radiology that your screw is out, you take out the screw and try to feel it. That feeling when you probe with the sound is like you are climbing the stairs. So if there is any violation, you will get into that hole. That your smooth climbing up or down the stairs will have a different feel. So what are the other methods that you look into? You look into neuromonitoring. You look at the triggered responses, the pedicles to screw stimulations. Oh no, there is a breach. Now what to do? This is what we encounter. So important is stop and think. Where is the breach? Is it an entry point problem or is it a direction problem? It may have been difficult to achieve a medial angulation due to soft tissue or a retractor. I tell my boys also, never do a pedicle probing or a pedicle all with your self-retaining retractor touching your probe. Two metals touching each other, you will never have a tactical sensation or a feel of the pedicle. So any metal should not touch a metal when you're doing this. And how to rectify a new entry point, intentional lateral entry point, or anatomical screw with the superior entry point may be a salvage procedure. So anatomical trajectory is achieved in 62% of the maximum insertion torque you can in a failed screw. So that's a good technique. So you look at the straightforward free technique or funnel technique or in and out. So any violation can be, you can change from one technique to another. Even a transverse process entry point can be used as a salvage method. This is use of percutaneous method. As Neeraj already said, this is when you start on the lateral wall. This is what you see on the lateral view. Once you reach the medial border of the pedicle in the lateral view, you should be in the body. So when you're trying to salvage a screw, and it's very important screw, so even if you are not doing a cannulated screw, you can use a cannulated screw at that level. So important is if you could get in your guide wire, do a tapping over a guide wire and use a cannulated screw. That's the most safest way to rescue a pedicle. So another is the transfacetal or the cortical screws, which are now transfacetal. I am not very great fan of it. Cortical screws were introduced by Medtronic and now I think have been discontinued. Always keep sublaminar hooks ready. These are important to save levels, especially in thoracic. Just to save time, I'm coming to the last example. This is the ophthalmologist we had operated. He has a dish. These are bad bones. It's very difficult to put a screw, but once they tend to become very, very loose. This quality of bone there's no elasticity in these bones. It's a lumbarized S1, so did a L4 to S1 stabilization with the TLIF. So he developed a post-operative right calf pain. No gross breach was seen on the X-ray as seen on the left side. We did a Doppler thing, then we might have a DVT, but the radiculopathy persisted. So we got a CT scan done, got through the sections, and there was the right-sided, that S1 was the culprit. Steroids didn't give much relief, so we opened up. This is the point which Vikas was telling me. To any rescue screw, you must do a laminotomy. If you just feel excited that you have seen a breach and try to just unscrew the screw, and it is an inferior or a medial breach, your screw threads will act like a knife and cut through the root. So it is important that you do a good laminotomy, see the root as it is here, do a good root retraction, all under vision, all probably under microscope. And this important step, you can actually, the main surgeon can do this and your assistant can actually remove the screw. So this is important. Rather than removing the screw is not important, but saving the nerve root is a more important thing. So this is how it is. And so see how the threads move. It would really have cut the root at multiple points. So it's all, and with the breech where which is more interior and a medial, it's quite a difficult to salvage it. So this we could finally could do it in the same level, and patient was relieved of the symptoms. So take home messages: YouTube, Google are not the learning tools for beginners. Mentorship, cadaver courses are must. The urge to put the screw doesn't make anyone a spine surgeon. Pedicle screw instrumentation in deformity like scoliosis remains a challenge. The scoliotic pedicles follow the morphological pattern as in a deformed spine, but show individual variability. Preoperative CT scan is essential to analyze the feasibility and planning of a pedicle screw instrumentation in these patients. In case of symptomatic breach, recognize the problem early and investigate. Most of us, when the patient says leg pain postoperatively, you tend to give him some steroid, some painkiller, gabapentin, and send him home. That should not be. Please investigate him. It will be another person's complication and not yours. So he'll definitely be after your life. Screw removal and reposition always under vision. Always master lumbar pedicle screws, then perform thoracic pedicle screws. Begin with trauma and later do deformity. Thank you.